Imagine an organ that is so incredibly resilient that you could literally chop it in half. It would just grow back, almost as good as new. It sounds like straight-up science fiction.
Oh, absolutely. Yeah.
But then imagine that same seemingly invincible organ can be completely and irreversibly destroyed just by taking like a handful of regular over-the-counter headache pills.
It is an incredible paradox. We tend to think of our internal organs as having these very straightforward mechanical jobs. The heart pumps blood, the lungs inflate and deflate like a bellows. The skeleton is basically just scaffolding.
Right.
We really like biology to be intuitive.
Right. We want it to make sense.
Yeah.
But today, we are looking under the right rib cage, and that neat, intuitive machinery just completely falls apart. We've gathered this really fascinating stack of medical history and physiology sources to explore a biological landscape that pretty much resists any simple definition. We are talking about the liver.
Yes, we are.
And the mission for this deep dive with you today is to completely redefine how you look at it, because it is not just some passive filter sitting in your abdomen. It's really the body's ultimate chemical factory. It's a frontline immune organ, and it's this master metabolic regulator.
The sheer scale of what it accomplishes, like every single minute, is staggering. The commonly cited metric is that the liver performs upward of 500 distinct chemical functions.
500? That's wild.
Yeah, 500. Though, honestly, when you read through the latest physiological literature, that number is less of a precise count and more of a scientific shorthand for, well, we just keep finding more things that it does.
Okay, let's unpack this. Just anatomically speaking, just to ground us, we're looking at a 1.4 to 1.6 kilogram reddish-brown gland. It's tucked right up under your right rib cage, sort of wedged between the diaphragm and the stomach.
Exactly, yeah.
And if you look at it on a gross anatomical level, it seems pretty unambiguous. It has 4 distinct lobes, right? The right, the left, the caudate, and the quadrate. But the sources make it very, very clear that this surface-level view tells you absolutely nothing about how it actually operates.
No, it really doesn't. To understand the liver, you basically have to abandon the macroscopic view altogether and zoom way, way into its microscopic architecture.
Okay, so what are we looking at down there?
Well, the entire organ is constructed from millions of these tiny functional units called lobules. Try to picture millions of tiny hexagonal structures just all tightly packed together.
Oh, like a massive microscopic honeycomb.
Yes, that is the perfect visual. And each one of those hexagonal lobules operates as a completely self-contained processing plant. At the dead center of every hexagon is a central vein.
Okay.
And ringing the outside corners of the hexagon are these crucial intersections that we call portal triads.
Triads, meaning 3 distinct vessels running together.
You're right. 3 vessels, right. So each triad contains a bile duct, a branch of the hepatic artery bringing in fresh oxygen, and a branch of the portal vein bringing in nutrients. So blood flows from the outer corners of the hexagon, funneling through specialized liver cells called hepatocytes, and they're all moving inward toward that central vein.
Wow, okay.
And as the blood percolates through that cellular maze, the hepatocytes are just aggressively inspecting it, modifying it, tearing molecules apart, and building brand new ones.
Which actually, that brings up a massive conceptual shift I noticed in the research. Because if you pulled a physiology textbook off a shelf in, say, 1985, the liver was overwhelmingly framed as just a metabolic clearinghouse.
Right, exactly.
It was just a place where glucose and fats and toxins went to be processed and cleared out.
Yeah, that metabolic framing completely dominated the 20th century. But moving into the 1990s and especially the 2000s, immunologists and gut microbiome researchers realized we were missing half the story.
Half of it.
Yeah. The liver isn't just a metabolic center, it is a frontline immune organ.
The sheer volume of immune cells stationed there is what totally blew my mind when reading this.
It's huge. Roughly 80 to 90% of the body's resident macrophages live exclusively in the liver.
90%.
Up to 90%, yeah. And macrophages are those heavy-duty immune cells that just swallow up cellular debris and foreign invaders. In the liver, they have a specific name. They're called Kupffer cells, named after Carl Wilhelm von Kupffer, who first observed them way back in 1876.
Okay. Kupffer cells.
Right. And these Kupffer cells don't just, float around. They are physically anchored inside the blood channels of those hexagonal lobules we talked about. They sit there, permanently stationed, just constantly sampling the blood that is rushing in.
Which totally ruins the most common analogy people use. I hear the liver is a filter, all the time. But based on what these Kupffer cells are actually doing, it's not a passive coffee filter just catching grounds. It's more like it's a highly secure border checkpoint mixed with a massive manufacturing plant.
That captures the reality much better, honestly. The Kupffer cells are actively interrogating the blood for, say, bacterial products leaking out of the intestines.
Wow.
Yeah, they make real-time, incredibly complex decisions about immune tolerance, meaning they decide, let this food protein pass, versus immune attack, meaning destroy this dangerous bacterial fragment immediately. It's actually the foundation of what researchers now call the gut-liver axis.
But for a border checkpoint to be effective, right, it has to intercept all the traffic before it goes anywhere else in the country. And looking at the plumbing of this organ, there is this singular architectural quirk that makes all of this possible.
You're pointing to the dual blood supply.
Exactly.
And this is arguably the most important mechanism to grasp if you really want to understand liver function. The liver is the only organ in the entire human body built this way.
Wait, the only one?
The only one. If you think about a standard organ, say a kidney or a bicep muscle, it receives one supply of oxygen-rich blood pumped straight from the heart via an artery. The tissue uses the oxygen, and then a vein carries the depleted blood away. Simple, right? But the liver plays by an entirely different set of rules.
Because it gets two incoming streams of blood simultaneously.
Exactly. Only about 25% of the blood entering the liver is that standard oxygen-rich blood coming from the heart. The other 75% is arriving via the portal vein.
And that's the crucial part, right?
Right. Because this blood is relatively low in oxygen, but it is incredibly dense with nutrients and potentially toxins.
Because of where it's coming from. And
Yeah.
I really want to make this super concrete for you listening. That portal vein is draining blood directly from your stomach, your small and large intestines, your pancreas, and your spleen.
Everything from the gut.
Everything. This means every single nutrient, every prescription drug, every sip of alcohol or bacterial byproduct that you absorb through your digestive tract does not go into your general bloodstream. It gets shunted directly to the liver first.
The liver gets the absolute first look at everything you ingest, period. In pharmacology and medicine, this mechanism is called the first-pass effect, or first-pass metabolism.
So if I swallow a pill, the liver basically treats it like a suspicious package at customs. It breaks down, or at least alters it, before it can ever reach my brain or my systemic circulation.
Yes. The liver possesses this vast, specialized arsenal of enzymes, chiefly a massive family called cytochrome P450, and they are designed specifically to dismantle incoming foreign compounds.
Okay.
So when a pharmaceutical company develops a new oral medication, they spend years calculating exactly how much of that chemical the cytochrome P450 enzymes are going to destroy on that first pass.
Wait, so they have to account for the liver just chewing it up?
Oh, absolutely. They literally have to overpack the pill with active ingredients, knowing the liver is going to destroy a massive percentage of it, just so the surviving fraction is the correct dose for your body.
That is so crazy. And I always wondered why some emergency drugs just can't be swallowed. Like nitroglycerin is a great example from the sources.
Oh, nitroglycerin is a classic case. It's given for severe, life-threatening chest pain to dilate blood vessels. If you swallow a nitroglycerin pill, your liver enzymes are so insanely efficient that they will completely dismantle the active molecule on the first pass. 0% of the drug will actually reach your heart.
0%.
Zero. That's why it has to be administered as a tiny pill dissolved under the tongue or as a transdermal skin patch. Those routes absorb the drug directly into the systemic veins, which entirely bypasses the digestive tract.
Right.
And that means bypassing the portal vein and the liver's first pass destruction altogether.
This also perfectly explains those little warning labels on prescription bottles about grapefruit juice. I used to think it was just an old wives' tale, or maybe some weird allergy thing.
Oh no, the grapefruit juice interaction is a brilliant illustration of this chemical factory in action. Grapefruit juice contains these organic compounds called furanocoumarins.
Furanocoumarins.
Yep, and these compounds bind to and completely inhibit one very specific, very important liver enzyme called CYP3A4.
And CYP3A4 being a heavy hitter in that cytochrome P450 Border Patrol family.
A major heavy hitter. Now, imagine you are taking certain statins for high cholesterol or specific blood pressure medications. The dosage you were prescribed assumes that CYP3A4 is going to actively break down a large chunk of that drug on the first pass.
Because they overpack the pill, like you said earlier.
Exactly. But if you drink a glass of grapefruit juice, you neutralize that enzyme. The border checkpoint is suddenly unstaffed.
So the drug just floods through the liver totally untouched.
And you end up with a massive, potentially toxic spike of the medication circulating in your bloodstream, far, far higher than the doctor ever intended, simply because you knocked out the chemical factory's dismantling mechanism.
Wow. The liver doesn't just dismantle things, though. I mean, it actively manufactures and manages our body's fuel.
Hmm.
And this manufacturing power led to what might be, honestly, one of the most significant medical breakthroughs of the 19th century.
You're talking about the work of Claude Bernard between 1848 and 1857. This completely revolutionized human biology.
It really did. Because up until the mid-19th century, the prevailing scientific consensus was highly simplistic. Scientists basically believed that the sugar in your blood came exclusively from the food you ate. It's just a strict mechanical input-output model.
Right.
Which would logically mean that if you stopped eating, your blood sugar should eventually drop to zero and you'd just die.
Under their model, yes, that's exactly what should happen. But Claude Bernard, who was this brilliant French physiologist, designed a series of experiments, primarily using dogs. He fed them diets completely devoid of carbohydrates or fasted them for extended periods.
Okay.
And when he tested their blood, he consistently found significant levels of glucose. And crucially, he found the highest concentrations of glucose in the hepatic vein. That's the vein carrying blood away from the liver.
So you proved the liver was actively creating sugar, not just passively passing along what came from the stomach.
Exactly. And in 1857, he proved it definitively by isolating this complex starch-like substance inside the liver tissue itself. He named it glycogen.
Glycogen.
He demonstrated that the liver synthesizes this glycogen from excess dietary sugar, stores it, and then possesses the chemical machinery to meticulously convert it back into glucose, releasing it into the bloodstream as an internal secretion when the body needs fuel.
Which is wild, because by proving the liver secretes substances internally, Bernard essentially founded two distinct medical fields at the exact same time. Hepatology, which is the study of the liver, and endocrinology, the study of hormones and internal secretions.
What's fascinating here is that Bernard uncovered the fundamental buffering mechanism that prevents us from passing out every single night when we sleep. Think about it. You can go 12, 16, even 24 hours without eating, and your blood sugar remains incredibly stable.
Here's where it gets really interesting, because the liver doesn't do this alone. It works in tight, constant communication with the pancreas.
Oh, yes.
When you eat a heavy meal, your blood sugar spikes. Your pancreas senses the surge and releases the hormone insulin. And insulin acts as this chemical messenger traveling to the liver and essentially shouting, pull this excess glucose out of the blood and lock it away in the vault as glycogen.
And the liver has a surprisingly large vault for this. It can store roughly 100 grams of glycogen, which is about a quarter of the body's total supply, the rest being stored locally in your skeletal muscles. But between meals, as your cells consume that circulating blood sugar, the levels naturally start to dip. The pancreas senses that drop and releases a different hormone, glucagon.
The counterpart to insulin.
Right. Glucagon is the key that opens the liver's vault. It commands the liver to break that stored glycogen back down into pure glucose and release it into the bloodstream.
It's like a hybrid car battery. It seamlessly switches between charging and discharging. When you're eating, the liver captures the energy and charges the battery. When you fast, it discharges that energy to keep the engine running perfectly smoothly.
That's a great way to put it.
And if the glycogen vault runs completely empty during, say, a really long fast, the liver doesn't give up. It just switches manufacturing lines and initiates a process called gluconeogenesis, literally building brand new glucose molecules out of raw amino acids and fat byproducts.
And that continuous silent buffering is exactly what keeps our central nervous system functioning between meals.
So Claude Bernard figures out this brilliant reality in the 1850s. But the historical sources we reviewed outline a much, much darker era before Bernard. Because for centuries, the scientific misunderstanding of the liver wasn't just a harmless academic error. It was literally a lethal one.
The history of hepatology is just filled with hubris. Even going back to ancient history, there was a profound, almost mystical obsession with the organ.
Yeah, Babylonian hepatoscopy, the Etruscans. The sources mention this famous bronze artifact from the 2nd century BCE called the Piacenza liver. It's a life-size map of a sheep's liver, partitioned into sections and covered in the names of ancient deities.
Right, the divination.
Priests were literally using the physical bumps and variations of sacrificed animal livers to try and read the future.
Which is, well, We shouldn't entirely dismiss that as arbitrary superstition.
Great.
Yeah, I mean, ancient peoples opened up animals and saw this massive, heavy, intensely blood-engorged organ. They correctly intuited that it was the absolute center of vitality. They just
Right.
drew the wrong causal arrow. Because it held so much blood, they assumed it must hold the secrets of the universe.
Right, right. But the real historical tragedy, the one that cost countless human lives, comes a bit later with Galen, the Greek physician in the 2nd century CE.
Galen's influence really cannot be overstated. Because human dissection was taboo in ancient Rome, Galen worked mostly from animal dissection, and he placed the liver at the absolute unquestioned center of his physiological system. He taught that the liver was the origin point of all venous blood.
Yeah, he theorized that nutrients arrived from the gut, and the liver literally concocted them into blood and yellow bile, which was one of the 4 bodily humors.
And this humoral theory elevated the liver to a status that often superseded the heart. And here is where the theory becomes extremely dangerous. Galen's model dictated that human illness was primarily caused by an imbalance of these humors, specifically an excess of blood being overproduced by the liver.
Oh, no.
Yeah. Therefore, the most logical, scientifically sound treatment for almost any ailment was to drain that excess blood away. It directly justified centuries of therapeutic bloodletting.
And this wasn't some brief medical fad either. This completely unchallenged, demonstrably false model dominated Western medicine for 1,400 years.
It's astounding.
It was still widely practiced in the late 1700s. I mean, it famously hastened the death of George Washington in 1799. His physicians, strictly following this Galenic logic to treat a throat infection, drained an estimated 40% of his total blood volume in under 24 hours.
It is a really stark lesson in how a plausible-sounding scientific theory can persist and cause immense harm when it operates without rigorous experimental checks.
Which brings us to a really vital connection for you listening today. We look back at Galen's bloodletting and think, how foolish to misunderstand the liver's capacity and cause such harm. But we are still doing a modern version of this today.
Unfortunately, yes.
We aren't doing bloodletting, but we casually consume everyday chemicals without understanding the liver's absolute limits, often with fatal results. Let's talk about acetaminophen, or paracetamol as it's known in the UK.
This is one of the most critical public health topics in hepatology right now. Acetaminophen overdose is currently the leading cause of acute liver failure in both the United States and the United Kingdom. And the mechanism behind it brings us right back to the chemical factory and those cytochrome P450 enzymes.
I always struggled to understand how a common over-the-counter painkiller, something you can buy at a gas station, can literally melt a vital organ.
Well, at normal recommended doses, acetaminophen is incredibly safe. Most of it is metabolized through harmless pathways. However, a very small fraction of the drug is processed by a specific cytochrome P450 enzyme called CYP2E1.
Okay, CYP2E1.
Right. This enzyme takes the acetaminophen molecule and inadvertently converts it into a highly reactive, highly toxic byproduct called NAPQI.
Toxic meaning it will chemically destroy the liver's own hepatocytes if left unchecked.
Exactly. Now, under normal circumstances, your liver actually anticipates this danger. It maintains a continuous stockpile of a powerful, internally produced antioxidant called glutathione.
Okay.
So the moment the toxic NAPQI is created, the glutathione binds to it, neutralizes it, and makes it water-soluble so you can excrete it safely.
So the body has a built-in neutralizing system.
It does, but, and this is the crucial part, it has a strict numerical limit. When someone takes an overdose of acetaminophen, the harmless metabolic pathways get totally saturated.
Right, they can't handle the volume.
Exactly. So a massive amount of the drug is shunted over to the CYP2E1 enzyme instead. The factory starts churning out a tidal wave of toxic NAPQI. The liver frantically uses its glutathione to neutralize it, but eventually the glutathione stockpile runs completely dry.
It's like a factory assembly line. The glutathione is the vital coolant. When you overdose, the assembly line producing that toxic NAPQI goes into overdrive, the coolant runs dry, and the reactive machinery literally melts itself down. The hepatocytes undergo rapid cell death, leading directly to acute liver failure.
That is the exact mechanism. It's why the dosing guidelines on those bottles are not suggestions, they are chemical boundaries. The metabolism flips from safe to lethal the very second you cross that glutathione threshold.
Is there anything they can do if that happens?
Fortunately, yes. If caught early enough, emergency rooms can administer an antidote called N-acetylcysteine. This compound provides the raw chemical building blocks the liver needs to urgently manufacture more glutathione and halt the destruction.
Understanding those chemical mechanisms really changes how we view symptoms of liver distress too. Because when the factory starts shutting down, it presents in ways that seem totally unrelated to an organ in your abdomen.
Yes, when you realize the liver is the body's primary protein manufacturer, the symptoms make total sense. For instance, the liver constantly manufactures a protein called albumin, roughly 10 to 15 grams of it every single day.
It sounds like a lot.
It is. Albumin makes up about 60% of your total blood protein. Its primary physical job is to generate osmotic pressure. Basically, it acts like a chemical sponge, holding water inside your blood vessels so it doesn't leak out.
Which explains a massive mystery for me. If the liver is failing and stops manufacturing albumin, that osmotic sponge is just gone.
The water literally seeps out of the blood vessels and pools in the surrounding tissues. This is why a classic late-stage presentation of liver failure is severe fluid retention, particularly massive swelling in the abdomen, which is a condition called ascites.
And at the same exact time, the patient might be bruising or bleeding uncontrollably, which feels completely contradictory.
It's a dual failure. Alongside albumin, the liver manufactures the vast majority of your blood clotting factors. Several of these crucial proteins require vitamin K to function.
Right, vitamin K.
The liver uses vitamin K in an enzymatic process called gamma carboxylation, which basically gives the clotting proteins the chemical sticky ends they need to bind together and stop a bleed. When the liver tissue is dying, it stops producing those sticky clotting factors.
So you present with a massively swollen abdomen and spontaneous bleeding, two terrifying symptoms that are simply downstream consequences of the same exact synthetic factory shutting down.
Precisely. Which brings us to an incredibly pervasive and frankly dangerous public misconception: detox culture.
Oh, the endless market of juice cleanses, detox teas, and liver flushes.
From a physiological standpoint, the entire concept is absurd. The public has been sold this idea that the liver acts like a lint trap in a dryer, accumulating toxins that need to be aggressively flushed out.
Right, like it gets clogged up.
But the liver is the body's detoxifier. Its baseline function is continuously dismantling toxins and converting them into water-soluble waste. There is zero credible clinical evidence that a commercial juice cleanse improves this enzymatic function.
And the sources actually highlight a really dark irony here. Many of these herbal supplements, particularly unregulated botanical blends sold for weight loss or bodybuilding, they are heavily documented causes of drug-induced liver injury, or DILI.
Oh, it's tragic.
People take this supplement to cleanse their liver, and the foreign botanical compounds end up overwhelming those cytochrome P450 enzymes, causing actual toxic damage.
Yeah.
The supposed cure literally becomes the poison.
It is a profound misunderstanding of the organ's resilience and its limits.
Another area where our understanding is shifting rapidly is how we actually label liver disease.
Yeah.
I'll admit, for most of my life, I assumed that chronic liver damage was virtually synonymous with heavy alcohol consumption.
That is a very common but increasingly outdated assumption. Alcohol is certainly a major cause of liver injury, but it has been eclipsed. In 2023, an international panel of major hepatology societies officially changed the medical nomenclature. They took the term non-alcoholic fatty liver disease, or NAFL, and replaced it with MASLD, metabolic dysfunction-associated steatotic liver disease.
It's a mouthful. But I assumed the shift was to get away from defining a disease purely by what it isn't.
That was the primary clinical reason. Defining a massive public health crisis merely as not caused by alcohol was, well, it was scientifically lazy.
Right.
The new MAMA-LD acronym forces physicians and patients to focus on the true underlying culprits driving the disease: metabolic dysfunction tied to obesity, insulin resistance, and type 2 diabetes. The fat accumulating in the liver is a downstream effect of systemic metabolic overload.
And the scope of this is terrifying. The sources estimate MASLD now affects roughly 1 in 4 adults globally.
1 in 4. It has silently overtaken alcohol and viral hepatitis as the leading cause of chronic liver disease in many developed nations.
And when that chronic disease progresses to end-stage failure, we enter the world of transplant medicine, which has also seen a really fascinating shift in how it operates. Specifically, how doctors decide who gets a scarce donor organ.
Decades ago, allocation relied on the Child-Pugh score. It was a useful tool, but it incorporated subjective clinical measures, like a physician had to visually judge how severe a patient's ascites, their abdominal swelling, actually was. But around 2002, the U.S. Transplant Network moved to the model for end-stage liver disease, known as the MELD score.
Because it removes the human bias.
Entirely. The MELI score calculates a patient's mortality risk using only objective, hard laboratory values. It looks at bilirubin, which is a yellow pigment from dead red blood cells that normally gets cleared by the liver. If bilirubin is high, the liver isn't clearing waste.
Okay, that makes sense.
It looks at creatinine, which signals that the kidneys are beginning to fail as a secondary consequence of the liver shutting down, and it measures blood clotting time. It is a statistically rigorous way to prioritize the sickest patients based purely on their biochemistry.
The frightening part is that catching this damage early, before you need a transplant, is incredibly difficult. You could have MASLD, and your liver could be 60% damaged, and you wouldn't feel a thing.
Not a thing. The liver tissue itself lacks pain nerve endings. A patient will only experience physical pain if the organ swells so massively that it begins to stretch the fibrous outer casing surrounding it, which is called Glissen's capsule.
Wow.
Because of this, conditions like MASLD or chronic hepatitis act as silent destroyers for years or even decades.
Which is exactly why routine blood work, specifically checking those ALT and AST liver enzymes, is so critical. Those enzymes are normally locked inside the hepatocytes. If they're showing up in high numbers in your blood, it means liver cells are breaking open and dying.
Exactly.
But if damage is occurring, we have to talk about the liver's ultimate superpower, the biological miracle of regeneration.
It is truly unmatched in human biology. A healthy human liver can regenerate and regrow to near its original functional mass from as little as 25 to 30% of its remaining healthy tissue.
It's astonishing. I mean, it's like cutting a starfish in half and watching it regrow, except we are talking about a vital, highly complex human organ.
This regenerative capacity is actually the sole biological foundation for living donor liver transplants. A healthy living donor can have surgeons remove roughly 60% of their liver to give to a recipient.
60%.
Yes. And within a matter of weeks to months, both the donor's remaining tissue and the recipient's new graft will hyperproliferate and regenerate to near full size.
Unbelievable.
This incredible procedure builds upon the pioneering work of Thomas Starzl, who performed the first human liver transplant in 1963. While his initial attempts failed, his persistence led to the first true survivor in 1967.
But there's a biological point of no return for this superpower.
Yes. The line is cirrhosis. In the early stages of liver disease, as cells die, they leave behind fibrous scar tissue. If you remove the underlying cause, whether you stop drinking alcohol, cure a hepatitis C infection, or reverse metabolic dysfunction, the liver can often dismantle that early fibrosis and regenerate.
Okay, so it can heal.
It can, but cirrhosis is the end stage. It is the point where dense, permanent scar tissue physically overwhelms and replaces the regenerative capacity of the cells. Once a patient crosses the threshold into cirrhosis, the architecture is fundamentally broken and reversal becomes highly, highly unlikely.
So what does this all mean? We've covered a massive amount of ground today. For you listening right now, why does understanding this intricate 500-job chemical factory actually matter to your everyday life? I think it fundamentally reframes how we ought to view our lifestyle choices.
I agree.
Knowing that the liver has this profound capacity to regenerate means that moderate, time-limited harm, perhaps a phase of heavy drinking in your 20s or a period of poor diet, is often highly recoverable. The organ actively wants to heal itself, but it demands respect. Sustained chronic harm, like unmanaged metabolic dysfunction or years of alcohol abuse, slowly pushes you closer and closer to that irreversible cliff of cirrhosis.
We absolutely have to respect the chemical limits of the factory. Our bodies are remarkably resilient, but they're absolutely not invincible. And if you think the liver's role as a chemical factory is fascinating, consider the implications of the gut-liver axis we discussed earlier.
Oh, right, the border checkpoint.
Remember that 75% of the liver's blood arrives straight from the gut via the portal vein. That blood is carrying millions of microbial metabolites produced by your gut microbiome, delivering them directly to the liver's resident immune cells, which leaves us with a profound question to ponder. If the liver is meticulously screening everything our gut bacteria produce before it is allowed to reach our brain or our heart, is the liver actually acting as the body's central intelligence agency, effectively deciding how and if our gut microbiome is allowed to influence the rest of our biology?
It turns out when you look under the right rib cage, you don't find a neat, simple machine. You find an infinitely complex, deeply interconnected universe calling the shots for the rest of your body. Thank you for joining us on this deep dive.